you can see fever, muscle aches, pains, headache, tiredness, mood changes, all those. Otherwise, if it is a localized inflammatory response, then it involves inflammatory mediators like bradykinin and prostaglandins. The blood vessels, glands, and nerves are involved. So you find there's more of sneezing, runny nose, congestion of the nose, cough, and so forth. These are things that will be you've been dealing with daily in your practice. So then how does somebody prevent? Sometimes somebody is traveling to a place where they know they're likely going to be at risk. They want to ask you, how do I prevent? They're not just looking for the medicines only. Apart from the medicines for prevention or for treatment just in case, if you give them some extra information on how to keep safe, they'll be better allies for viewers. So people should drink a lot of fluids, okay, like juice, maybe about 8 glasses of water per day, okay? People should wash hands, much like we are doing during coronavirus. Eat fresh food and drinks, fresh fruits and vegetables, okay? Enough rest, proper exercise, regular exercise, okay? Using a mask, we can call a face mask, okay? And then relaxation, we've said that before. Then there should be probiotic foods can also be useful, okay? You avoid being rained on because it increases the cold, okay? Take care of yourself during the season change. If it's cold, keep warm, okay? Avoid close contacts with people who have, and then eat a variety of food groups at a minimum of 5. Now, if you find somebody taking maybe boiled maize with uji, that is only one category of food. So it's good to have a variety of foods, okay? And then garlic. Garlic is a magic. You realize garlic is antiviral, it's antibacterial, antihypertensive, anti-diabetic. They've got quite a lot of benefits, health benefits. Of course, on treatments, we will say, see a doctor. A doctor here includes us, the pharmacists. So people should see you, and then probably they give you medications, or they will give some other methods of prevention or improvement of your quality of life. Okay? So over the counter, what will these people be looking for? Or people come to you, say, I have this cold or congested nose. What exactly should they be given? Some decongestants, like pseudoephedrine, okay? So that the nose can be not be blocked anymore. Antihistamines, like diphenhydramine, a first generation antihistamine, will cause some dizziness, it will cause somnolence, which is good sometimes, because sometimes someone has got a cold which is even preventing them from sleep. They'll be killing two birds with one stone. You are reducing the sneezing and runny nose, but you're also allowing them to be able to sleep. Most of the time, people have headaches and sore throat pain and some body aches. So there'll be some pain reliever, but you need to clarify to the patient that they don't need to rush antibiotics. I know people, the first day they get a cold, they come and ask you, do you have Augmentin? Do you have Zinat? You need to emphasize to the patient that if you just started having these symptoms today, there's no fever, or if the fever is low-grade fever, there's no evidence of infection. As a good antibiotic steward, you'll tell them, no, you don't need this. And if they insist and you tell them, no, you don't need that, they may be annoyed a bit, but when they go and check, because they always check, they'll realize you are the right person. So they'll come back to you next time, okay? Now, some symptoms here of what to do, because we said mainstay is symptomatic management. So for fever, we give some analgesic and antipyretics like paracetamol, ibuprofen. Headache, again, we give the same. Muscle aches, also the same, and sore throat pain, even sinus pain. Okay. For nasal congestion, we give sympathomimetics like oxybenzolone, salmeterol, all those. Pseudoephedrine and rest. For runny nose, we give anticholinergics so that we can reduce the production of fluids like diphenhydramine, chlorpheniramine, oxylamine, all those. Usually there's also some cough. So you can give antitussives like the methotrexate, diphenhydramine, and sneezing, and give sedating antihistamines like lifenadamine. A number of times you will find a combination of all these, okay? Like in this very well proven product called trihistamine. I started using trihistamine when I was a child, and I saw it through campus, and I'm glad it's back to the market currently after disappearing for some time. So in that, you'll go and find a number of these ingredients trying to solve the problem simultaneously, so that you don't have to give different medication at the same time. Okay. Then we go to what is a common cold. The second condition is allergic rhinitis. This is an atopic disease presenting with symptoms of sneezing, nasal congestion, clear rhinorrhea, and also rhinitis. Why do we say it's atopic? Atopy is a tendency to develop allergic reactions. When you say somebody is atopic, it means they're more likely to develop allergic reactions. If you didn't know that, that can be a good learning point for today. It's an immunoglobulin-mediated immune response due to inhaled antigens. Okay, so either this could be an immediate, or if it is there's a late phase, it will be leukotriene mediated. Okay, I hope these ones can be visible. They are fairly small, and then on the epidemiology, it's about 30%. Okay. It peaks on the second and fourth decades of life. In other words, those who are in their 20s and 40s, is it no 30s and 40s, no, 20s, yes, 20s and 40s. Those people have a lot of this condition, then it gradually reduces with time. Okay, it is also very high among pediatric patients. Okay, according to the International Study for Asthma and Allergies in Childhood, 14% of those who are between 13 and 14 years, and 8.5% of those between 6 and 7 years have symptoms of rhinoconjunctivitis linked to allergic rhinitis. So you can see the percentages are not that small. Okay. Now, comparing the adults and pediatrics, seasonal allergic rhinitis is more common among children, whereas the chronic form is more common in adults. 3.6% of adults miss work, and 36% have impaired work performance due to allergic rhinitis. So even though they could not miss work because of maybe economic reasons, it still impairs their ability to perform. That's why we take it seriously and we bring it to such a forum. What are the risk factors? Atopy. Being somebody who is atopic, there are people who are more likely to develop allergic reaction than others. Somebody says, I'm very sensitive to dust. That's somebody who is atopic. The male, okay, the male gender is more commonly going to be affected. If you are born during a pollen season and you got very early exposure, then that also is a risk factor. If you're a first child, it's a risk factor, okay? Use antibiotics in early age. That's why we should always discourage parents from imagining that they need to cover the children with antibiotics every time for every little condition, even one child is self-limiting, okay? If the mother is a smoker, then that can predispose the child, because the mother is always the child more commonly, and that smoke itself can be making the child to be more prepared for a reaction, and for that matter, they end up having the problem. If there's contact with indoor allergens, like fur and dust mites, another factor, then there are aeroallergen, sensitization in the children, and food allergies. Okay? Now, let's compare between males and females. Okay? Allergic rhinitis in males, in the female, it is more predominant in adulthood, except in Asia. When looking at that, we look at both the gender and the region. But in the males, it's more prominent in childhood, but in Asia, it's also in adulthood. Okay? Now, among the females again, the main allergens are dust mites and Gamenaceae. Okay? Gamenaceae is a family of monocotyledon plants, That includes wheat, corn, and rice. Okay. Now, again, that's for the female. For the males, the main allergens again are dust mites and ragweeds. Okay. Yeah, remember, if you wonder what a ragweed is, these are plants in the genus of Ambrosia, family Aster, and then they're distributed in the tropics, mainly in the Americas. Okay. Now, back to what we are saying. Main symptoms in the females is rhinorrhea and itching. Okay. For the males, it is mainly nasal obstruction. There's a higher symptom burden in the females, but it is less in the men, at least for once. We get something where the men are more relieved. Symptoms worsen when linked to estrogen fluctuation. That's why actually we have a lower burden as men. Then there is a high level of substance P in females, yet in the males, it is mainly due to IgE. Now, what is substance P? Substance P is an 11 amino acid long neuropeptide, which is expressed either in the CNS, PNS, and the immune system. So that is responsible for that problem. Now, there is also high mast cell degranulation in females. In the males, there is low level of nasal eosinophils and low level of eosinophil cationic protein. In the females, there's association to hypothyroidism and associated with CRS without nasal polyps. CRS means chronic sinusitis. Polyps is a condition, okay, that can cause frustrating symptoms like pain and nose stiffness, and even loss of smell sometimes. Okay, so that is how it compares between AR compares between males and females. So, according to symptom duration and severity, we can classify allergic rhinitis into 4 different categories. First is intermittent, which is if the symptom lasts for less than 4 days every week, okay, or 4 consecutive weeks, or less than 4 consecutive weeks. If it is persistent, that means the symptoms go for more than 4 days per week, or more than 4 consecutive weeks, no matter how many days per week. If it is mild, then there's normal sleep, no intermittent daily activities, no impairment of daily activities like sport, leisure, and usual work. Even the work or school or your attendance of this seminar is not affected. The symptoms are also a bit mild, they're not bothersome. However, we can have moderate to severe, where the sleep is interfered with, okay? Daily activities like sport and leisure are impaired. There's a problem with work or going to school, and the symptoms you feel are bothersome, okay? So generally, what are some of these symptoms of the AR? We have red and itchy watery eyes. I hope none of you is having that, and so bad. Sneezing, congestion, and runny nose, itchy or sore throat, or nasal drip cough. Okay? And then there's fatigue. You can see from this photo, this person is looking sleepy. Okay? What are the triggers? Outdoor allergens like dust, okay? Pollen from trees, grass, and weeds. Indoor allergens like dust mites, pet dander, that is the fur from the pets. Mold spores. Thank God we don't have a lot of pets in our setting. In some cases, it's a big problem. So what is the mechanism of AR, allergic rhinitis? The allergen either go through the mast cells or T and B cell interaction, and that causes IgE production. Then through some chemical mediators, you find that we have got either an early phase reaction, doing itching, sneezing, rhinorrhea, nasal congestion. Otherwise, if it is leukotriene, triene, or prostaglandin, or kinase mediated, you will find that there will be a late phase having nasal congestion, hypersensitivity, and rhinorrhea as the symptoms, and this is mediated through eosinophils, neutrophils, monophils, or basophils. Okay. Now, how do we prevent? We had seen for common colds. For allergic rhinitis, we need to wash our beddings regularly. When they're dusty and dirty, we are actually going to have a problem. Dust either your office or your home frequently. When you do that, wear a face mask so that you don't dust them in to trigger more of the allergic rhinitis. Okay? Rinse nasal passages. Okay? You rinse your nose. Wash hands after playing with pets. Shut windows during pollen season. Avoid smoke and fragrances. In our setting, there's no serious pollen season, but for those who come from certain regions that have a lot of grass, it might be a problem. Okay? About treatment of allergies in general. Okay? Now we can use nasal sprays if there's symptoms of nasal congestion, all that. We may also use allergic shots. There's nothing to do with a gun here, it's just an injection. We can use antihistamines and decongestants, just as we have seen also with common cold. Most of the time they come together. Okay? Prevention. Okay? Now, we should first of all note that there is no unnecessary diet restriction during pregnancy and lactation. Okay? Again, we need to have proper breastfeeding the first 6 months of life. This will actually, people usually used to say that if you breastfeed well, then you'll be robust and you will not be able to succumb to several conditions. And that's true. The first 6 months of breastfeeding is properly done, improves immunity. Then you can consider hydrolyzed formula milk in high risk infants if exclusive breastfeeding is not possible, not feasible. You may also introduce complementary foods from 4 to 6 months of age when developmentally ready. Importantly, also control air pollution, avoid smoking, whether it's passive or active, control indoor air quality, control weight and avoid obesity, avoid stress if possible, go for immunizations, don't misuse antibiotics, and if you have these conditions, start treatment early and you control them. Okay? So what are the options we have? Okay? We have got allergens avoidance. Okay? That is very important. Just in case you are not able to avoid them for one reason or the other, you can use oral antihistamines. Okay? It is also important to consider international corticosteroids, but the red there is because they should not be used habitually because of side effects. If you can avoid, or if you can use a combination where the amounts are minimal, then that's better. We may also have leukotriene receptor antagonists like zafilcast and montelukast. Then we can have allergen immunotherapy. Okay? Now, if you are to compare allergy, nasal congestion due to allergy versus nasal congestion due to cold, because when you are managing them, you need to know what's the difference. Is this guy allergic or is it that they have got a common cold? In case of allergy, it's triggered by allergens like pollen, dust mites, and dander. Save that. But in the case of nasal congestion, it's due to a viral infection. Nonetheless, the fact that there's an infection here does not warrant use of antibiotics because it's viral infection. Now, in allergy, we find persistent clear nasal discharge, sneezing and itchy, watery eyes, swelling of nasal passages. Whereas in case of nasal congestion due to cold, you have starts nose with thick yellow-green nasal discharge. So these are some of the questions you may be asking the patient. If it's a discharge, how does it look like? When you are asking that, you are trying to check, is this just an allergic condition? Or is it due to cold? Okay? The sore throat, cough, mild fever, swollen nasal passages due to inflammation. And on the treatment side, if it is due to allergy, of course, antihistamines will be very important. International corticosteroids can be used, and then advise people to avoid allergens, because that is the final ultimate solution. If you can avoid the allergens, the better. Treatment for nasal congestion due to cold, we can use decongestants as the mainstay, advise the patient to rest, hydrate themselves, and give symptomatic relief, like some antihistamines and some analgesics. Okay? Then, most important thing to note is that do not just, somebody comes and says, I have got common cold, or I have got allergic rhinitis. Then you just decide to give maybe an antihistamine. That is not effective. Most of the time you need triple action. You need some anti-allergic, and then you have a decongestant, and then you also need an expectorant if there's a cough, or demulcent if there's irritation of the throat, or at least an not antibiotic, but analgesic. So a minimum of 3 categories of medicines to target different things will most likely make the patient be satisfied. Otherwise, they'll use that histamine for a long time when they're still feeling pain, or the nose is still blocked, which is not very good. Okay. So in case of allergy, you have diphenhydramine, which causes instant relief from acute allergic symptoms. We have promethazine, a long-acting anti-allergy with some anti-emetic effect. Then we have decongestants, okay? Mainly diphenhydramine again. Diphenhydramine is a classic antihistamine. I think it should be the first antihistamine to be developed globally. So you'll find it very commonly referred to as a reference point. And then expectorants like sodium citrate, ammonium chloride helps in clearing the mucus. Okay. You may also give a demulcent like menthol to reduce throat irritation. Okay. So diphenhydramine blocks histamine H1 receptors. Remember what histamine does to the body from your classes of immunology and even pharmchem. When you're doing pharmaceutical chemistry of antihistamines, you first of all do that. You're trained about what histamine does to the body, the histamine pathway, and then diphenhydramine classically blocks the receptors. It goes to the receptor ahead of the histamine to prevent the effect. So it prevents effects of histamine on the physiology of the body, like vasodilation, capillary permeability, flare, itch, and some smooth muscle contractions in the bronchi. Okay. It also suppresses histamine-induced salivary, lacrimal, and respiratory secretions, so that you don't have runny nose. Okay. It does not inactivate histamine or prevent its synthesis or release. That one will relieve to things like sodium chromoglycate that prevents its release. Then this one also works very well. Now, promethazine, on the other hand, is also an important antihistamine with longer duration of action compared to diphenhydramine. The longer duration of action is mainly because if you look at the structure of promethazine, the 2 aliphatic aromatic rings on the left of the structure are joined. That cyclization or the joining of those 2 rings gives the longer duration of action. It also has got some pain relieving effects because of these local anesthetic effects, and also some anti-adrenaline and atropine-like effects. All those put together make it very, very popular. Okay. We can also have ephedrine, hydrochloride. Most of these antihistamines are formulated as hydrochloride salts. A few like chlorpheniramine come as chlorpheniramine maleate. I think chlorpheniramine is also in trihistamine. It activates beta adrenergic receptors in the lungs, causing bronchodilation to relieve the cough that you could be getting because of bronchoconstrictions. However, it stimulates heart rate and increases cardiac output. So you should use it judiciously in patients with cardiovascular disorders, especially hypertension. If somebody is of advanced age and they are hypertensive, then they come to you with these symptoms, try to avoid products that contain ephedrine or pseudoephedrine. Okay? You can go for products that contain dextromethorphan instead. Now, it also increases peripheral resistance of the vessels. We also have ammonium chloride and sodium chloride, and it irritates stomach mucus lining and trigger gastrovagal reflex that enhances the respiratory secretions. Okay, they help produce less tenacious sputum, so it makes it easy to cough it out. In most expectorants, you will see ammonium chloride also there, or sodium citrate, which also acts as a reflux expectorant. making sputum less thick or less tenacious, and so easier to expel. Okay. Now, let's look at DEG. This is diethyl glycol. Why? It's because some people normally illegally put it in some expectorants and some cough preparations because it is more affordable, but it is very toxic, okay? It's a toxic industrial solvent, sometimes illegally used as a cheaper substitute for glycerin or propylene glycol in pharmaceuticals. It's an industrial solvent, so it should not be used. It's highly toxic, particularly to the kidneys and nervous system, okay? Even very small amounts can be very dangerous. The symptoms include abdominal pain, vomiting, diarrhea, altered mental state, renal failure, and potentially even death. It caused a lot of deaths in Nigeria recently, and some products had to be called from the market, I think less than 20 years ago. So historically, instances include multiple outbreaks worldwide, where concentrated cough and cold syrups led to poisoning, okay, especially with children, because they're used mainly in syrups, which are taken mainly by children. That's very unfortunate. So the presence of DEG in medicinal syrups often results from poor regulatory oversight. If we cannot sample products, and when products are being sold in the market, the work of the regulator to sample and recommend before people get hurt. Inadequate testing, intentional malpractice by manufacturers, corruption, all these are dangerous. Okay? So what are the take-home messages from this presentation today? One, the common cold is caused by rhinoviruses, leading to upper respiratory inflammation and symptoms like runny nose, sore throat, and cough. And allergic rhinitis is known to peak in the 2nd to 4th decades of life, and gradually it declines. Okay? Now, relief from common cold, allergic rhinitis, nasal congestion, for us to have that proper relief, we need to have a triple action. Approach it by giving a combination of medication, okay? So because we are pharmacists, and for that matter, we are so interested in the medications for the antihistamines that we are likely to be seeing as constituents of this product. We'll see diphenhydramine, a first generation antihistamine, anti-H1 receptor blocker, H1 receptor blocker that reduces histamine effect. We also have promethazine hydrochloride, which is a potent antihistamine with a longer duration of action. Then there's ammonium chloride that reduces tenacity of the sputum so that it makes it easy to cough out. Ephedrine that activates beta adenosine receptors in the lungs, causing bronchodilation. And then sodium citrate, that is a reflux expectorant that also again reduces tenacity of the sputum so that it's easier to expel. And most importantly, let's watch out. Even if you are not in the regulatory section, if you find that there's a possibility of DEG present in a product because of the way children are responding or the patients, you need to report this. Pharmacovigilance